My name is Dr. Doug Jenkinson, and I am the originator and chief investigator of the Keyworth whooping cough study, which commenced in 1977, soon after I became a partner in the Keyworth medical practice in Nottinghamshire. In that year, there was a large outbreak of whooping cough in the practice, mainly in the under fives, and I recorded details of every case. I continued recording all cases of whooping cough I could find in the practice thereafter, and at the present time, early 2013, after 36 years, I have accumulated records on 728 individuals. This is over 10 times the national reported incidence over the same period. Yet demographically, Keyworth is similar to most other practices, and all the cases have manifest the classical symptoms of at least 3 weeks of the characteristic paroxysmal coughing. Because the Keyworth practice is rural, discreet, and served only by this one medical practice, it is possible to draw the conclusion that what whooping cough does in Keyworth is probably what it does in the rest of the United Kingdom, and possibly in other similar countries. There are 2 whooping cough issues that are important. Firstly, how to reduce the large number of cases in infants under 4 months of age, over 500 in 2012 with 14 deaths, roughly double the rate in the preceding 12 years. And secondly, how to improve the clinical diagnosis of whooping cough in older subjects, in whom it is a very unpleasant disease that can cause physical and mental morbidity, and if unrecognised, unnecessary investigations. The Keyworth study has published much important information. In 1978, it was the first for 25 years to publish evidence of the effectiveness of the vaccine, at a time when it was seriously called into question, and helped to ensure that, unlike Japan and Sweden and some other countries, the United Kingdom continued to use pertussis vaccine, saving many lives as a consequence. In 1988, I published data showing that vaccine efficacy appeared to drop quite rapidly after a course was completed, and in 2001, to improve the duration of benefit, pertussis was added to the preschool booster in the UK. In 1995, I published details of the clinical course of 500 consecutive cases of whooping cough, which, as well as quantifying the nature of the modern disease, showed how little difference there was between whooping cough in the immunised and whooping cough in the unimmunised. What the Keyworth study can tell us today is that a large part, if not all, of the officially measured increase in cases in adults is a misconception. They have been there all along, but missed. This graph compares the incidence of whooping cough in England and Wales with Keyworth as cases per 100,000 population. You will see immediately that there is an enormous difference between the blue Keyworth line and the red national line, and that the difference has got greater as years have gone by, until 2012, when the difference reduced for reasons I shall come to shortly. You will rightly ask if I am overdiagnosing. Here are some figures to show it is unlikely. In 2002, I diagnosed 44 cases, all with classical symptoms, and a similar number to 1996 and 1990. 14 were confirmed by swab, a further 9 were tested serologically and were positive. This is a high proportion by any standards. This small practice in rural Nottinghamshire was responsible for 5% of all the notifications in England and Wales in 2002, over 200 times the national rate. How is this discrepancy explained? Why are most cases missed? The reason is simple, and it is that doctors think it is diagnosed by hearing a child with the characteristic cough. This is completely wrong. What they do not realise is that they are never going to hear the cough, and that most cases are now in adults anyway. In the 1940s, there were 100,000 cases a year, almost all in children. 1% died. Every GP was familiar with this nasty disease of children, with its distinctive cough that nearly every person in the land had heard and could recognise. Then immunisation came along and notifications fell drastically to about 10,000 a year by 1974. There was another peak 35 years ago as a result of the pertussis vaccine brain damage scare. But for the last 30 years, pertussis vaccine acceptance has been at a high enough level to render whooping cough relatively rare. Certainly rare enough for a generation of GPs to grow up never having heard it and being unprepared to diagnose it, especially in adults. Previous generations of parents told the doctor the diagnosis. It is almost impossible to diagnose unless somebody tells you the diagnosis, because the doctor will never hear it. The cough only lasts for 2 minutes or so, an average of 13.5 times a day. This graph of cases by age group in Keyworth shows the number of cases in adults is completely at variance from the national figures. The Health Protection Agency figures showed that in 2011-12, 90% were in the over 15s for the first time. The Keyworth study suggests that cases in adults of 15 and older, shown in the blue line, have been at the current level for the last 30 years and have simply been missed. The reason the HPA figures only recently show a lot of adults with it is almost certainly the result of serological testing, which became widely available in 2006. Prior to this, the only possible test available to GPs was a pernasal swab, which few kept or knew how to use, and was usually negative anyway by the time the disease was suspected. Getting a blood test is easy and sensitive. There is a third factor at work too. The internet has made it possible for adults with a severe prolonged cough, and dismissed by their doctor as just a virus, to diagnose themselves and go back and tell their doctor, who can now easily test for it. The bottom line is that now, probably because of the preschool booster reducing it in older children, infants are now more likely to catch it from a parent than a sibling. The increase in officially confirmed cases is exactly what it says and correlates with the use of blood testing, which in practice has only been known to GPs for 2 or 3 years. This increased recognition phenomenon is technically called ascertainment. What the Keyworth study has shown is that there has been a lot of it about for a long time, but everybody has missed it. If the recent ascertainment increase makes this better known, then that is helpful, because one of the likely strategies for reducing whooping cough is repeated immunisation. And that may not succeed if we continue to miss whooping cough, and as a consequence the public does not see the need. The high number of 10,000 confirmed nationally in 2012 is still nowhere near the true figure. In Keyworth we confirmed 7 times as many as the national average. If you are unfortunate enough to get whooping cough, it will be the worst cough you will ever have had in your life. The paroxysms of coughing will exhaust you and make you feel you are suffocating. You will frighten anyone who happens to see you. Some will want to call an ambulance. It will go on for months and your doctor will examine you and tell you it is a virus or some kind of asthma. You are convinced you have a serious lung disease, possibly fatal. It eventually gets better and you've come to no harm. This failure to diagnose problem is an international one. I know this because I have a website devoted to providing information about whooping cough and helping people to diagnose it for themselves. I get many emails about frustrated attempts to get diagnosed. This site has been running for 13 years and gets 3,000 hits a day. I have noted with some pleasure that in the last few years an increasing willingness of doctors to consider the diagnosis and test for it. So how do you diagnose whooping cough clinically? The main characteristic of whooping cough that makes it clearly distinguishable from other coughs is the long periods when there is no coughing. It causes intense paroxysmal coughing for a few minutes, followed by an hour or more when there is no coughing at all. Patients are unaware of this generally and will not describe it. They will describe a bad cough, but are usually unable to describe a paroxysm accurately. And certainly they won't describe the silences between. There are usually no abnormal signs and the patient looks well. It will last from 6 to 12 weeks. Vomiting, whooping can aid diagnosis, but the clinician will have to describe a paroxysm to discover it. But you will only diagnose it if you consider the possibility and ask. I will end by reminding you that whooping cough in infants, especially under 4 months, who are the most likely to get it, is serious, severe, often atypical, and may simply present as a sick baby with a respiratory illness obviously needing hospital admission.